We have a wonderful physician with us today, Chhavi Mehta, who presented to us in person in Palo Alto at Stanford Neurology years ago, and we're just so happy to have her back with us virtually today to present about her amazing leadership of quality improvement at the flagship Palo Alto Medical Foundation, which is now affiliated with Sutter. She's also the medical director of clinical improvement for the entire Sutter Health Network. So thank you for squeezing us into your busy schedule. Next slide, please.
And thank you. Thank you so much, and thanks for having me.
We've got lots of flex room in our agenda today.
Thank you. Well, thrilled to be here, and thank you for having me, Hattie. And you're right, I did present. It was pre-COVID. We had a in-person meeting at Stanford. So what I'm going to share today with this group is that what we are trying to do to optimize cardiovascular risk factors for our patients, particularly as it relates to blood pressure control. And I'm so impressed with what Dr. Rana presented and the work that Kaiser is doing. They have been leaders and pioneers in this work. So I'm going to present some of the work that we are doing here at PAMF. Now, Palo Alto Medical Foundation, we are in Northern California. For those who don't know, primarily, I mean, we are from Santa Cruz all the way up to along the 101 corridor, all the way up to Daly City and also in East Bay. So a very big footprint. We have about 2,500 physicians in our group. Next slide, please. So what you're seeing here, this information is probably not new for this audience. We all know that there is a direct correlation between elevated BP and cardiovascular disease or coronary artery disease and stroke. And in fact, hypertension has the strongest evidence of causation of CAD and strokes, as you can see in these charts here, where you see the absolute and the logarithmic risk of coronary artery disease or stroke as the systolic and the diastolic blood pressures go up. So extremely important that that we pay attention to this for our populations. So next slide. So what I'm showing you here is that emphasizing that blood pressure control for our patients is extremely important and commitment for our organization. It is a HEDIS quality measure, and also it's a value-based care metric for us. So we have incentives tied into this measure as well. Important from population health perspective to control BP, reduce cardiovascular risk. Now, we did see a big drop in our control rates in 2020, which was the pandemic year, the COVID year. And since then, we've made some steady progress each year to improve the health of our, improve blood pressure control in our population. So next slide. So I'll walk you through our process and our tactics, some of the clinical pearls that we have implemented in the last few years. So as with everybody, we always want to start with the data. The data tells us the why and what we do next. So that data analysis is extremely critical, as you would all agree. So in this chart, you are seeing the analysis of our Medicare Advantage patients, and this is for last year that we did. So we saw that the key to improving performance is improving the follow-up, because our follow-ups were just not, close to 30% of the patients did not have a follow-up after their blood pressure, after they kind of came to the clinic, their blood pressure was high and they did not have a follow-up. So 30% is a big number. We know, we all know what our, like primary care visits are busy. There's patients have a lot of issues that they want to talk to the doctor about or to the clinician about, and sometimes there's just no time. So if you go on to the next slide, what we also did next was then do a little bit more deep dive into our uncontrolled hypertension patients. And this is just an illustrative example of our Medicare Advantage patients. So our goal was to gain some insight into what is happening with our uncontrolled hypertension patients. So we did sample chart review of about 90 to 100 patients to get a sense of what is going on. And obviously, there was a large chunk of patients, about 30%, which were seen by non-primary care. And these are the specialties that are not, like they don't do blood pressure control. They're not engaged in that. So these are specialties like urgent care, or it's like dermatology. So they do check blood pressures in their offices, but then they don't manage them, right? So that was a big chunk or a big part of this puzzle. White coat hypertension, which means that patients have home blood pressure readings which are under control, but when they come into the office, so that white coat effect was about 18%, and clinical inertia was about 19%, that the patients had high blood pressure, but it wasn't addressed at the time of the visit. So this gave us a sense of what is the actionability and what are some of the tactics that we can implement to improve blood pressure control for our patients. So next slide. Um, so based on the learnings that I just showed you, which are data driven, and these are some of the learnings that we have seen, not just 1 year, but previous year as well. So not surprising. So what we did was that we have a comprehensive, so we took a comprehensive and sort of a continuous process improvement approach to tackle this issue and kind of design some tactics. So what we did was to categorize these tactics into population-based approaches, like these are the patients who are our patients, whether they are coming in to see our clinicians or not, whether they have a clinic visit or not, how do we take care of these patients? And then what can we do or what are the tactics which are geared towards our physicians and APCs, both in primary care and specialties? And what can we do in terms of clinic workflow optimizations and patient education? So I'll walk you through, I'll describe some of the tactics that we implemented for this. So next slide. So at the population-based level, looking at this from the whole population lens, so we designed and implemented a year-long outreach for patients with hypertension. This includes reminders to schedule appointments with PCP in a timely fashion, and also inviting patients to send us home readings for select patients. I think we did have a big emphasis on home readings. We saw in the guidelines, right? The European guidelines came out at the beginning of this year, and there was a lot of emphasis on home blood pressure readings, especially when multiple blood pressure readings are taken and you average them out. They're much better reflection of blood pressure control. So a lot of effort around educating patients on how to take blood pressures at home, creating some standard handouts and other materials, and also partnering with our health education team to educate patients on how to check blood pressures at home, and creating that pathway in Epic so that patients can easily send us the home blood pressure readings. So inviting select patients to send us home readings, and then downstream workflows with RNs and pharmacists. And this is using the bulk outreach feature of our Epic AMR. We are on Epic. And in addition, we have clinic staff that also outreach select patients via telephone, where we need more engagement. So we have this process continuously going on throughout the year. So this is what we do for population based. And we have pretty good yield, what we call from this. We have a good percentage, and I don't have a slide for that, but we have a high percentage of patients who do schedule appointments or will send us home readings when we outreach them. Next slide. So clinic workflows, how to optimize clinic workflows. Now, our clinic workflows that we implemented are evidence-based. So the guidelines did tell us that, if you and they do emphasize a lot on the correct blood pressure techniques, right, for in-office blood pressure readings. So all our MAs trained, and they get retrained in the correct office blood pressure measurement techniques. And we did implement this whole a very successful campaign of second blood pressure check. So if the first blood pressure, initial blood pressure is greater than 130/90, our MAs automatically within a minute or two will check a second blood pressure and report that as a visual cue to the physician to act on. So, and this is again evidence-based. And what we have seen in our data that when we do a second blood pressure check, the blood pressure improves to normal levels in 35% of the cases because the patients have just walked into the clinic, their blood pressures are high. And also it gives an opportunity for the physician because, different clinics have implemented different ideas for this. Some will stick a heart on the computer or some of the, or on the door so that the physician or the clinician gets they're just reminded that the blood pressure is high and not to ignore that. And then if there is white coat effect, then the MAs send My Health Online messages to patients with the questionnaire attached to it. So that's an automatic way of which patients can send us blood pressure readings and not having to type in. So this is specifically for history of white coat hypertension. So we did a lot of messaging and socializing the home blood pressure readings this year, which was new for us as compared to last year. Next slide. Now, what are our tactics which are geared towards our clinicians? We do maintain our own Sutter hypertension guidelines. We did update them to the European guidelines that came out in the beginning of the year. So we have access to evidence-based treatment intensification protocols and evidence-based follow-up after treatment intensification, because that was the gap that we were seeing. Now, guidelines say that patients can be followed up as soon as 4 weeks after titration of medication is done. And that is what was our gap that we saw. Now, access to PCP appointments is an issue. So we did kind of encourage shared medical appointments, or based on the availability, based on the clinic and what resources they have, also having our APCs run, let's say, like a one afternoon of hypertension clinic where they would do follow-ups for hypertension. So a lot of work done on this. And then I talked about the home blood pressure readings for patients with white coat hypertension. Now, another opportunity for our gap for us was the handoff to primary care from certain select subspecialties. So what we did was that we created a agreed upon sort of a guideline for specialty department to guide care. So if a patient is in dermatology department where they don't manage blood pressures, then they have some sort of a guidance to say, okay, this is the level where I need to send the patient to the emergency room, or a 1 month appointment with PCP is okay, or this patient needs an immediate appointment with PCP. And we kind of had these channels of communication open on using Epic to do so. So that is again like as you saw in our data, right, 35% of our patients that were uncontrolled their blood pressures were measured at some non sort of primary care, a non like cardiology, endocrinology sort of a setting. We do have done CMEs for hypertension, grand rounds for hypertension, for especially geared towards our primary care clinicians, so that we have some sort of last year and as well as this year, so that any updates that are there for as far as treatment or follow-up or intensification, all our clinicians are aware of that. So next slide. This year, we also have what we are calling My Panel reports so this is a clinician having, individual clinician having insight into how they are doing. So reports up to that level, which are in Epic. And right now, we only have it for our Medicare Advantage and MSSP, the Medicare Fee-for-Service patients. But the plan is to expand this so that the individual clinician can see how they're doing, they can pull their patient reports and take action if needed. Next slide. Now, this is something which I'm very excited to share, that Sutter has launched. It was just happened this year that Sutter has launched a digital care program designed to help patient monitor and manage health conditions at home. So hypertension was their first sort of thing that they took, and it's AI enabled, and it's led by pharmacists and health coaches, and it provides eligible patients with a digital blood pressure monitor with the capability to send readings directly to patients' electronic health records. So there's a capability to send multiple readings, and not only to kind of track and manage blood pressure in real time, but also have those predictive algorithms to see which patient, based on their history, will be out of control, right? I mean, in the next month or in the next few weeks, and kind of take a preemptive action on that. So that program for us just started in March. It's available to select patients right now, but the plan is to sort of expand that, and also to include like statins and other cardiovascular risk factors as a part of this program. I think this is what I have to share. There's a lot of work that we have implemented and done, and we have seen a continuous sort of increase in our hypertension control rate. And our biggest gap was the follow-up, the availability of PCP appointments. I mean, chronic disease, the better the more the patient is followed up, and the more the patient is the medications are titrated in time, the better the control they have, right? And that you couple with health education, because at the end of the day, it's like, do they understand their, do they understand what is going on with them, and do they have the capability of managing it themselves? Like, that's true for diabetes, that's true for hypertension, that's true for statins. And so we have, I think, with the implementation of Sutter Sync, our access issues with PCPs will be largely solved, so that our patients will be seen in the manner that they should be seen. I mean, if you are titrating or trying to bring a hypertensive patients under control, then you should be seeing them ideally every 4 weeks. And I don't know if our PCPs have the capacity to do that. So I'm hopeful, and I'm very excited. Thank you so much.